Good morning, everyone, and welcome from Mount Sinai Hospital in New York City. Vishal Kapoor, and my partner Karthik Guja welcome you this morning. We apologize for a little change in our dates. Usually, like we know, we do it on the fourth Wednesday of the month, but because of some technical issues, we had to prepone it. We preferred preponing instead of postponing the whole show. So we're again this morning on April 22nd. Before I take you to the lab, we just wanted to give you an update. As you know, you can go to our website, ccclivecases.org, to view any of our previous live cases in the archive section under the peripheral icon. You can also register for our annual Mount Sinai Link Symposium, which is scheduled this year from June 10th to June 12th, June 10th being the Endovascular Fellows course, and the 11th, 12th being the main endovascular symposium per se, where all the international faculties, very well renowned, will be here discussing their thoughts, reviewing cases, and having a good argument and discussions here. So without further ado, I'll say good morning to PK. Good morning, PK.
Good morning, Vishal. Good morning, Karthik. We're here back in the lab again. Thanks so much for, I guess, coming a couple of days early. But I got a great team, and we're ready to start with a great case. To my right is our fellow attending, Dr. Atul Kukar, who's the Director of Cardiology at Mount Sinai Queens, which is our sister hospital. Next to him, we have Sardar Farhan, who's our endovascular fellow, and next to him is Asma Khalik, a little bit shorter, but she's there. She's also our endovascular fellow, who's graduating in June. So we've got a great team here. We've got Elizabeth, Damien, and the entire team. But before we get started with this nice case, which I think is going to illustrate a lot of the current issues that we're dealing with in endovascular, I want to take a moment to just talk a little bit about our Mount Sinai Link, or Link Mount Sinai, this year, which is very different from the years past. As you and Karthik know, because you guys helped me, I mean, we're continuing with the Fellows course, as we always have, but we've added a lot of nuances to Link Mount Sinai. First and foremost is, the aortic section has been pared down basically because SVS is at the same time as Link Mount Sinai this year, and we felt that the vascular surgery turnout may be less than desirable. So we decided to really pare down and leave out the aortic section. But what we decided to do was build on this on multiple other aspects. Dr. Robert Lookstein, who's our Director of Interventional Radiology here at Mount Sinai, has really taken the lead in developing the venous curriculum. And if you go on the website, www.linkmountsinai.org, you'll see that the venous curriculum is very, very robust with world-renowned leaders, to talk about all the different aspects of venous disease. As far as the main endovascular symposium, what we've done is we've continued with our technical forum or scrubbing with the experts forum, where we're going to show technical cases, 1 hour long each case from beginning to end. But also in the main symposium, we've incorporated a lot of debates. So we've got debates on common femoral artery disease, DES versus DCB, CTO, bypass versus not necessarily for CLI. And also for CLI, a lot of different techniques have also been talked about. The role of angiosomal versus versus direct versus indirect revascularization, pedal access, et cetera, et cetera. To handle the controversies on DCB, we've actually formed a panel. And what we're going to do is we're going to have a DCB town hall in which we're going to have moderated session where all of you can participate in asking questions to the experts regarding drug-coated balloons and where we're going with the current controversy with Castanos' paper. But beyond that, we've added a non-GME or CME accredited session where industry experts, industry leaders are going to be there, and you can ask industry directly, about OBLs, about anything that you want to ask in terms of where our field is heading. And this is a non-GME, a non-CME accredited session, which is about a 30-minute session, but it's a rare opportunity for all of you to really sit with, I'm talking about the leaders of Medtronic Peripheral, the leaders of Bard Peripheral, the top guys and gals who are making the decision. That's another part of it, which I think is very important. And finally, at the behest of our Dr. Karthik Guja, we've created an outpatient endovascular section symposium, which he's heading up, which is basically talking about all the current trends, approaches, and some controversies in OBL and management of PAD in the outpatient lab setting, which I think is very relevant to today's care of these patients. So I'm sorry for that exhaustive little introduction, but I think it's important because we're about 6 weeks away or 8 weeks away from Link Mount Sinai. So I wanted to let you guys know in a brief sense what this is about. So after this, we're going to let Dr. Sardar or Dr. Asma go ahead and present this case. I don't know who's decided to do it today, and we're going to get started.
It's my privilege today to present. Hello, everyone. Our patient is a female, 71-year-old. She complains about bilateral lower extremity claudication, progressing towards resting pain on the left leg. She has a past medical history of hypertension, diabetes treated with insulin, and hyperlipidemia. And she was a smoker up to the last intervention, which she received for the right SFA, which was also a CTO, and treated by Dr. Kukar and myself about 1.5 or 2 months ago. And she is on optimal medical therapy with a statin. She has her diabetic medication with insulin and metformin. She's on an ACE inhibitor, beta blocker, aspirin, and clopidogrel. Her most recent ABI was on the right side 0.82 and on the left 0.64. If you see the next slide is the most recent obtained vascular ultrasound study after the intervention on the right on the right SFA, showing that there is only a mild stenosis in this segment, and the arteries below the knee are patent. On the left side, you see marked in red, the left superficial femoral artery is occluded in the proximal segment. Which leads me to the next slide, which is the angiogram, and unfortunately, due to a formatting issue, this images will not play.
We took it here. Why don't you show it here?
But we have the first angiogram was, which we performed here was the, sorry.
There you go.
Here you see an angiogram runoff of the left lower extremity arteries, and here, as you see, there is a CTO from the ostium of the SFA up to the distal segment, and we have a good good runoff of the below the knee arteries. So, and this is a DSA angiogram showing the ostial occlusion or ostial CTO of the SFA, and the next image shows the reconstitution. I'm sorry. Yeah, that's it. That's the reconstitution of the SFA CTO with a good distal target.
That's a great case. And you know, I think Dr. Kukar, this is a great case that you brought, which really illustrates where we are right now. So in the contralateral leg, Dr. Guja and Dr. Kapoor, you know, the lady received what we thought was contemporary therapy. She got drug-coated technology, drug-coated stents. Now with the FDA warning letter, a lot of us have moved away from using drug-coated therapy because of the fact that we really don't know where we stand at this stage. I mean, I think we have our opinions and our beliefs, but there is still a very strong statement from the FDA and a very strong meta-analysis that's out there that I think we have to take seriously. So at this stage, a couple of thoughts. You know, how would you deal with this? First of all, let's talk about the technical aspects in a second. But before we do that, let's talk a little bit about how your approach to these kind of patients in your practice is. Are you guys, talking to the patients? What are you doing? Do you use drug-coated balloons? Do you not use drug-coated balloons and or stents? So I'm just curious to see what your thoughts are. We'll start with you, Artie.
Well, I was using drug-coated technology almost exclusively up until just a few weeks ago when PK informed me that we are not using that at Sinai anymore without specific consent, specific conversations with the patient. So I have pushed away from it, and I'm going, I guess, backwards in time a little bit and using more covered stents as well as bare metal stents when needed, and trying to use a little more atherectomy, especially a recent use of lithotripsy, and trying to get away with just balloon angioplasty after some form of atherectomy or vessel modification.
So what about you, Karthik, Vishal? What are you guys doing?
Go ahead, Vishal. So, I mean, again, I agree with RD. I mean, especially with this FDA letter and the warning.
I can't hear you, Vishal.
Okay, I'm sorry. So I guess I agree with RD. I mean, especially with this FDA letter mandating increase in mortality and transient, whatever the intermediary data is, it's becoming harder to justify the use of DES or DCB, especially in patients where you provide them objective, where they don't have much knowledge about the trial and the data and arguments. So I've unfortunately gone back to the old times where we do atherectomy, bare metal, stenting essentially, or worst case covered stent if you need to. But as of now, I've backed off essentially almost 100% from my drug-coated technology.
What about you? What about?
Yeah, I think same thing, PK. I think we have always been a no stent kind of program, right?
Right.
So I'm still, I think, when we had DCBs, we were doing DCB, atherectomy and DCBs, or, DES if it's necessary. But I think I've just gone back to atherectomy and balloon at this point of time, because I think based on the data, we get like around 78%, right? Restenosis rates, so 78% patency rates, which is, I think bare metal stents give you around, 83 now, going back to their original data. So probably Supera is more, but if you're talking about long stent like this, which is you're talking about at least 300 millimeters, right, of stenting.
Right.
So I don't know what patency rates of data we'll have. So if you're lumen to lumen, I think I will sit and see. If you don't have any dissection planes, I think leaving with atherectomy and just plain balloon, aggressive debulking, of course, and plain balloon might be okay.
Well, the problem is, part of the argument would be, I know Dr. Sardar presented the case, and Sanchit did a great job, but if you look at this lady, rest pain is subjective. So if you look at objective evidence, obviously an ABI 0.6 may not produce rest pain by the data. But the lady is obviously dangling her leg over the bed, and at night she's got feelings of rest pain. So ankle pressures, would help. But here, if you do just an ABI of a blood pressure of, say, whatever it was is going up right now, her ankle pressures are probably definitely above 60.
Yep.
So therefore rest pain is unlikely. So the question would be, well, what would you do? Okay. So would you send this patient for a bypass if she has a vein? And I guess Dr. Kuka, being the cardiologist, could answer that. Or would you say, would you have a conversation with them saying that, listen, there may be some high restenosis rates, but we can make you feel better. We'll follow you closely. As things change, we'll go ahead and take over. So Artie, I'm going to leave that one to you.
Yeah, so one of the logical conversations I try to have with the patient is to say that things are changing. The technology is going to change over the course of the next 6-12 months, and I think it's more the data is going to change. And what I find myself when I approach these cases with something this long is I would actually probably go more with a debulking, but I may spot stent. And I think the shorter bare metal stent we use, especially for if there's a re-entry point or even at the ostium, to put something there that's going to have a little more support for her. But overall, I think nowadays we're stuck. We're going backwards, and we're going to have to reinvent what we used to do and make it better.
So that's a great point, because the point is you're not going to leave them untreated. She's quite symptomatic, right? She's quite young, and I think she needs to do her activities of daily living. So the issue becomes from my perspective, is how do you not burn a bridge to future therapy? And I think the answer is what Artie's saying, or what you're saying, Karthik, is trying not to stent the entire thing. The other question is, what about a covered stent? I mean, let me argue with you. She has 3-vessel runoff. If you look at the Japanese data with covered stenting, with the newer covered stenting, the patency rates are phenomenal, right? Which just started. She has a good inflow with no inflow disease. So why not covered stenting?
So PK, I think it comes back to what's happening now is, right. About 5 years ago, we didn't have any drug-coated balloon technology. We were doing covered stents and bare metal stents and everything, but we know that there is a future for drug-coated technology. I mean, I know there is a speed breaker here on what's happening, but just covered stenting itself, the restenosis of covered stents is what we have to deal with, right? That's what gives us the biggest problem here. So.
No, I mean, I agree. I mean, the whole idea, like PK talked about, is not burning bridges. So what we want to do is always keep an option of having a bypass as an option, as a plan B in this patient, especially if her symptoms get worsened or if she has very quick restenosis, because we know she has good 3-vessel runoff. So her patency rate, if the vein is still available, will be excellent. So probably do an endovascular approach, trying to do IVUS, hopefully intraluminal, do spot stenting, not put the stent all the way across, and clinically follow the patient closely, both from an ultrasound perspective and a physical exam, and then hopefully we bite the bullet and
okay. So I think that makes a lot of sense. So what we decided to do was use an angle catheter, and anytime you have this sort of weird takeoff, you want to go ahead and use an angle catheter to get in. Right. So we're in the angle catheter in, and what we're going to do is we're just going to advance a glide wire. And I think part of what Karthik and Atul were saying is that we need to maintain the safety of these patients, right? So that's not where we want to go. Pull back a little. So we need to figure out safety-wise where we're going here. and you don't want to create an issue when it comes to safety. So obviously, this is not going.
PK, I think, even if you stent her, I don't think we're going to burn the bridges in this patient, because the reconstitution happens in distal SFA. I think the pop is pretty
Still
okay
good.
to be, I think the target is still going to be good, right?
Yeah.
And I think you created a nice knuckle there. So I think
So
it's
I
great.
think I think part of everybody, I mean, the whole idea here is, you're not gonna try to stent. I mean, you're not gonna try to be intraluminal. You can argue with me all you want, blue and gray in the face.
Yeah.
The bottom is, it doesn't make a difference. Anwar, Bobby, of our good friend, push forward, presented a nice paper which he hasn't published yet, which talked about subintimal versus what is it called, true luminal crossing.
Yeah, no, that's true.
And you know about that paper, and it's very good. You can push forward. Very few patients really not going. Okay, twist it. So there you go. So now we're just going to go ahead and follow it.
Beautiful.
That's a nice loop.
So now
It's a nice
the
knuckle.
loop, the same thing is here. You just don't want to get it into a side branch if you can help. I'm just going to try to straighten out that loop a little bit, and then Asma is just going to push forward. So the whole idea is I'm trying to keep the loop as small as I can, and then try to go, and then as she pushes. So, obviously we are subintimal. We have to accept that.
Yeah.
And what we'll do is we'll just do a little roadmap here to see where to get back in. But I mean, the problem is, the reality of this whole situation with DCB is that it's created us to make difficult decisions. The whole point is, we had the opportunity, and it's interesting to me that go ahead, advance. That even though most of the deaths have been adjudicated in the impact trial, they still keep asking. Stellarex came out with this with this through the 3-year data that showed very clearly that they had no additional mortality in the DCB arm as compared to the bare metal and compared to the bare balloon arm. So to me, I'm very curious to see, first of all, at Link Mount Sinai how our results go. And then after that is to see, well, can I have a talker on this? For us, after that, to really see what the FDA decides, because I think it's really going to impact our field, And the question is, what is happening with the FDA?
I think you crossed it, right?
Yeah.
You pop through.
So I just try to cross it at the cap. Okay, good. That's fine. So I think that's the situation where the issue is going to be is where are we going to go? Because guys, the problem is what's going to come up is if you and I are going to stent these patients, we're literally, the field has gone backwards now to 2010, 2009 when we had no other options, and I think it's very concerning to me what how this is going to end up.
Yeah. Agreed.
Yeah, so you're already back in I mean, that was a great demonstration of how to keep the loop very small and within the area of dissection, whatever plane you have created. And I
Get
think
us an
that's
IBIS, guys. Give me a not a bare wire. You want to atherectomize? Okay, get us a bare wire. So again, see, so this situation is the problem, right? So we believe in this. Our fellows believe in this. The problem is, if you look at the atherectomy data, there is no long-term atherectomy data.
Yeah.
Sure.
You and I can't say we have 3-year data with atherectomy that shows X, Y, and Z. We cannot say there's randomized control trial with Supera that shows that Supera is good at 3 years. You've got single center registries. You've got different types of studies that actually show it, but you don't have enough. So that's the issue that I have with all this. And so I think at this stage, do we go back to just plain old POBA? Which, by the way, we know doesn't work.
We know. Patency rate at 2 years is less than 50%, so it's pretty much like a 50-50 chance.
I think PK, at this day and age, don't you think if you do POBA for any patient, it's literally like doing it's not justified on any patient. I think it's disservice to the patient giving any patient POBA. No.
So the argument would be is why not Supera? You can, but the problem with Supera is it's limited as well because you don't have the ability to hit the ostium.
Yeah.
Right.
Yeah.
And so what are you going to do in the ostium? That's an issue. Do you just put an Everflex in and leave it with the Everflex? What's the matter?
Yeah. I mean,
I think at least through the
okay.
Yeah, I would probably put some kind of mechanical support in the vessel and not leave pure old POBA. Like I said, if DCB was a thing in play, we would have used that and got away with it. But going back to POBA, it just doesn't feel right. I guess it's a habit
a
of
small
Yeah,
vessel.
we're in a twig. See that?
Yeah.
Yeah.
So we're in a collateral. Yeah, we're in a collateral. I went in a collateral. Show me up.
Probably one of the genicular collaterals,
Yeah,
you know.
looks like it.
Yeah.
And it's running just like the posterior tibial would.
Yeah. I mean, it's a.
Is that crazy?
right there.
Right there.
You want to take a roadmap here?
Yeah, you got that.
There you go. All right, let's take a DSA again. Always when you guys get into a collateral and the patient complains of pain, take another picture and see what's going on. Inject. You might have a perf that you have to deal with.
I'll be fine.
That's the vessel I went into right there. That little collateral. Just wait. And so what I normally do at times here is just turn off the angiomax. Turn off the angiomax for a little, guys. And then we'll see what's going on. So we're now across. I'm sorry, Karthik. When you said ouch, I lost my concentration.
No,
What were you saying?
No, I was just saying that doing a plain POBA for patients at this point of time in our field is disservice to the
A
patient.
little bit more. Yeah.
So I think you can put a supera across. I mean, we can still put a supera, right? You need around 200 millimeters of stenting here.
Ivis, guys.
So you can put the supera across the adductor canal area, and then you can put a regular Everflex or any other bare metal stent on the top.
Yeah, because we'll see how this one looks with Ivis, but the question is, what are you planning on doing after you're done? That's the question, right? That's going to be in terms of what's the long-term outcomes. So as we know, the fracture rates with listen, durability was there. As you know, durability for long lesions, which is the fluoroplase, which is the Everflex trial, was unimpressive. So the issue is, where are we going to be with this kind of lesion? This is such a long lesion, stenting such a long lesion.
No, the problem is we don't have other options. The only option is essentially using a bare metal stent. So either we use a bare metal stent or we just do a POBA and get out.
PK, it's a high takeoff of the AT, right?
Yeah.
So is your filter across the?
Well, I'm going to have
the
to do that because, Karthik, the problem is that I think that our atherectomy nose cone is going to get in the way if we keep it too high.
Yeah.
So I'm gonna take that risk here and go a little bit lower. So let's get an eye.
So what kinds of atherectomy device are you planning to use here?
Well, I
What's
think
your
here,
thought?
like Artie was saying, luminal gain is going to be very, very important. And I think we have to use a directional atherectomy. There's really very minimal calcium, although on the other side, they use the shock wave, which I think probably was more calcified than this one.
Right.
So therefore, I think that we're going to use a directional atherectomy and then do a prolonged POBA, and then leave it. We can just leave it with a atherectomy POBA or atherectomy stent, and I think we decide afterwards. Floral, please.
So PK, we are ivising now to see.
I was to see how I cross, Karthik,
Okay.
just to get an idea. Look at the plaque burden. As it is, we know there's already going to be a lot of plaque here. Record, please. So we're recording tremendous plaque burden here. We're not dissected here. We're in the distal zone, and we're coming back.
I think you entered the cap very nicely, though.
But
so.
you can see how much plaque there is
Yeah.
here, Karthik.
Yeah.
Look at that.
Yeah.
That's what makes me worried. If we just do
Beautiful.
if we just do a POBA or just a directional atherectomy without drug, I think this is, you're talking about Asma and I were looking at the Vibrant study with even the bare metal stent arm in the Vibrant study was 24% primary patency rate at 3 years. So it looks like we're interluminal so far. So it looks like we did a pretty.
Can we have a chroma flow in case, just in case? It just helps.
Turn it off and on, Chief, and put chroma flow on.
It just gives better visualization.
Chroma flow. Chroma flow? Nope.
No? Okay. No, that's fine. I mean, chroma flow, you can't see the plane essentially well, but you can see how the vessel is flowing, but it looks good. Oh.
Record. Yeah, there's no flow.
I mean, you're right.
So I think you're intraluminal in most of the areas here.
Yeah.
Looks like we are. You
Yeah.
can see the
Right
structure.
there.
Yeah.
Structure all the way around, all the way to the top. Look at that. Yep. So even with the J loop, you can be intraluminal. Ah, yep.
Right
yep.
there.
So you are intraluminal. Okay.
Beautiful.
So now let's go ahead and get the atherectomy catheter.
So I think aggressive debulking at this point of time. right?
But Karthik, we know from our own study here that aggressive debulking results in adventitial injury, right?
Yep.
Right.
So adventitial injury without drug is gonna cause us to have even more aggressive restenosis. So what I've moved away is from aggressive debulking is to debulk in order to promote stent expansion. I think we need to get a well-expanded stent here, and you could argue that a balloon is enough. You're right, it probably could be, but I definitely think that debulking does help reduce our dissections as well. So with balloons, so I think that what I'm going to do is I'm going to do 2 aggressive passes. Show me above, please. And what I want to teach everybody is when we do this CTO, we do a daughter. We go all the way down, just all the way down. You can see the nose cone is so large with these devices. And this is going to tell us how this device is going to go. Go up, please, all the way up top. So what I'm going to do up top is I'm going to ask Sardar to just give me a little die. I want to make sure that I'm not in the common femoral. A little die, please. See, I'm still in the common femoral. I'm going to start right about there. On, please. And I'm just going to go very slowly.
So PK and Atul, for both of you guys, let me ask you a question. So I know PK, in your mind, you want to stent it, right? I'm
please.
assuming that's what you're thinking.
On.
Because
Yeah, I mean, do I want to stent it? I agree with Atul that I think we have to stent this.
okay.
Off, please.
So and you are doing debulking to increase the stent expansion or get a better stent expansion. Would you go with
please.
any other device other than Silverhawk?
Looks like we're already full. Looks like we're already full. Leave it there. We're at 15.
That's
I'm not going to get as aggressive a debulk as Silverhawk. I know that. Open another one so we can be faster. Because we're just doing this for live case purposes.
What's your thought on using specialty balloons like scoring balloons, angiosculpt, or chocolate in these cases?
Can I be honest with you, Vishal? You got a great point, and I don't think we have any data to show that Silverhawk is better than any of those things.
Yeah.
So I think you're absolutely right. You have no data to show one way or the other. I just think about cost and reimbursement. At this stage right now, if I debulk, I'm adding cost, but I'm adding reimbursement, and I'm not harming the patient. I know that I am going to allow myself to get a bigger lumen and prevent dissections. So therefore, I'm just going to go ahead and use the Silverhawk or any atherectomy device, followed by balloon angioplasty and then spot stenting. That's all I have at this stage without drug-coated technology.
Artie, what do you think?
So I'm curious to know why you picked the Hawk for this case. It's a long lesion. Usually the Hawk you pick for more focal lesions. Although I know we're a very big Hawk center.
Well, no,
I may have gone with laser with this one.
Well, I don't think, but the problem with the Hawk, you're not going to get the luminal gain you're going to get with Hawk with anything else.
Yeah.
Yeah, laser I would probably reserve it for where you have a lot of calcification, where you have a lot of problem with deliverability. Laser works, and in ISR, where actually laser has proven where it works. But in this case, like PK is right, you probably Hawk is great, or any other atherectomy device to get more luminal gain. So, but again, it's like it says, a dealer's choice, because there is no one versus the other comparison available in the market. So it just depends what you're comfortable with and what you know how it works.
Show me down.
Artie, I know we are not a big CSI center, but what do you think
Off.
about CSI in this case?
Off.
Yeah, that's so CSI is pretty much one of my
Show me above.
main
Push forward,
go-tos.
please.
Right.
Thank
That's
you.
why I'm
Exactly.
asking. I know you're a CSI guy, so.
Yeah, I mean I think CSI would work well as well.
I absolutely don't agree with CSI. I don't think you'll have any luminal gain here with CSI. There's no calcium. And I think CSI is not going to be an effective tool here. Give me a little forward.
Vishal,
Forward,
what
die,
do you
die,
think?
No, I mean,
Die.
I agree. It's Hawk would work great in this case. So I mean, I'm not that I'm against CSI, but in this case, a Hawk might give us a better controlled atherectomy than CSI.
So
PK, let me
you
go ahead.
see what happened there? The Hawk kind of buckled, and I think that's why you have to be a little careful with the Silverhawk. You don't want wire wrap, and you don't want it to cut in the same plane on.
PK, I'm seeing that you're doing 4 cuts, or you're doing 2
I'm
cuts?
just going to do 2, Karthik. I don't see any value in doing 4 anymore.
Okay.
I think that the old debulking strategy is gone, in my opinion.
So PK, let me throw you a curveball. I know you believe that when you have a door, why enter through a window? Would you have gone pedal in this case and done everything pedal for the people who believe in pedal?
On, I think it's ridiculous personally. I know that a lot of people believe in it, and I'm not poo-pooing it off. I believe that the field should advance, but I think the field should advance with reason. Okay, if you look at the complication here, show me above, please. If you look at the complication here from the groin, it's extremely low. Okay, and we went with the 7 French just because of the fact that we wanted to demonstrate to our audience how this is. So with pedal, you'd be putting a 5/6 slender into a very small vessel. As you saw, this lady has a very small vessel. Okay, and you would be doing debulking from below, which doesn't make any sense. Off.
So, Karthik, let me ask you from an OBL perspective, would you have changed your strategy?
So, I'm a Sinai guy. So, even though I'm an OBL, I have a Sinai guy. I know PK knows. I never do from pedal unless it's really necessary. So, I'm a big antegrade kind of a guy. But PK, if you really look at it, I know I would not do it, but you can really argue that if you really look at it, if you go from pedal, you can actually use a supera, which is a better stent than any BMS, right? And you can nail the ostium if you stent from below, right? So you're actually throwing in probably doing a better service to the patient by going pedal. I would not, but I'm saying I would want to get to your thoughts. And RD, what are your thoughts?
Okay.
So actually, the reason I brought this case to PK's
5-0?
attention was to go pedal.
5 or 6.
Okay.
And I think my luck with flush occlusions has shown me that it's sometimes better to start pedal and to be ready from the top. I didn't expect. PK really nailed this one beautifully. This is not what I expected to happen with the flush occlusion. I didn't even see a nub, and I took 3 or 4 different views. So I was either going to try to go antegrade, but really. I really felt that pedal was what was going to be needed, which is why I thought this would be a good case to present here.
No, but I think that, the whole point is I think we have to show that you can show the amount of plaque we got out, and this is tiny. And I know the surgeons always, but we have another full nose cone. The surgeons always laugh because they do remote endarterectomy and they get out like this entire column of plaque, and we show the little bit that we get. But so the perspective is that this is great that it shows that we are debulking, but the point is, are we really doing enough is the question. And I think that with our data that shows that obviously that restenosis is higher when you have intimal injury. What's the matter, honey? What's the matter? You okay? All right.
PK, this is a Dorado balloon?
Dorado balloon.
Okay. It's a 5-0 or
5 or
6-0?
6-0.
Yeah,
Squeeze her carefully.
You want to turn is the angiomax still off?
We turn it back on.
Okay.
Señora, ¿cómo se siente? Dolor? No mueve la cabeza.
She's going to feel a bit more right now, especially with that CTO.
¿Qué parte? ¿Debajo de rodilla or arriba de rodilla?
PK, I think it's a very good result after, at least pretty decent result after 2 cuts, no?
Okay.
Nothing, right?
Lo siento. Usa más medicina. Her pain's
Right,
above the knee.
26 is right for entry point.
So you can see here we're going up with the balloons, a 6-0.
Lo siento, usa más medicina para la dolor.
And you can see that it's not quite expanding. So we're going to go up a little bit higher.
There you go. I think you got it.
The proximal segment will open up
10.
right there.
And you can see this is the problem. You see up top how it's not expanding well. Very, very fibrotic. Down. So what we're going to do is we're going to come back up. We're going to crack this a little more. And I think this is kind of the problem that we always face with these.
So PK, you think more debulking would have helped?
Might have.
Okay.
Stay down, please. Stay lower for me. I just want to see. I want to stop the balloon. So I don't want to miss.
What do you think,
right
Vishal?
there.
I guess so, but a good balloon expansion will give us good results as well. That's the whole idea about doing PTA is look how the expansion doesn't happen completely, even though angiographic might happen, right? The spot right there in the center. There it is.
12.
The question is, would you have done more cuts?
I would probably have done a couple of more cuts because it's a long segment CTO with a lot of fibrotic lesions on IVUS.
Yeah, you saw how fibrotic this is.
Yeah.
Right.
Down.
So any amount of debulking gives you better expansion, hopefully, and then give you better results.
And
But it's a gray line.
This is sort of the time where you want to use a 7mm balloon if you have to put in a supera. Give me a little squirt here. Let's see the ostium.
To put in a 6 or supera, you're saying?
Yeah.
Okay.
Little dye again.
I'm just probably skeptical about the part. If I have to use 2 superas, then probably a 5-5
Go
down
up
and
here.
a 6 proximally. But since, like you said, she's a small, petite lady with vessels not such humongous, I don't know, 7 balloon.
7 balloon is a little too aggressive, PK, don't you think?
Yeah, I know. We always perf with that stuff. I know. 10, 12, 14, 16, 18, 20. So we go to 20 atmospheres with this balloon. Really
PK,
get
so
the expansion down.
I know now that you have used a debulking device, right? So atherectomy device, I know your reimbursement is good now. Do you think after using that, using a scoring balloon would have helped?
I mean, I don't know. It expanded really well.
Yeah.
So to me, I look at the expansion of the balloon. I'm a little worried about the fibrotic nature of this lesion. And I think when Sardar works this out, he's going to watch the filter. But I think I'm going to hold the sheet. So I think that fibrotic nature of that lesion is worrying me, because if I put a regular nitinol stent in, I know it's not going to stay open. And that's part of the reason whether I should go with a 7.0 Dorado and then put a 5.5 Supera. We'll take a picture though. I mean, we don't have you and Vishal to deploy it, so that's an issue. Ready? Because you guys are the best at deploying this. Inject.
Yeah, I think that's a very important point, that the restenosis rate in the Supera is markedly different depending on how well it's deployed.
So we only balloon till 30, and you can see that there is a little dissection. The vessel looks like, you know what, afterwards.
Yeah.
You know, so, I mean, this is the question. Inject. You could argue just leave it like this.
No.
I mean, you could, listen. I mean, it's going to come back regardless. So
It's the problem is 20 to 25 PK.
Yes.
Well, that's the problem that hold on, I'll take a look now. We'll analyze it together. Inject.
And the ostium also will be an issue. I know. Ostium will be an issue.
Poo-poo.
I would just stent.
I am. So, okay. Where's the pain? ¿Dónde está el dolor?
PK, would you take a calf picture again just to see? Because she's uncomfortable.
There's not a lot of pain in the calf. I think she's bleeding.
La dolor está
Yeah.
arriba de rodilla o debajo de
guys.
rodilla?
We'll take a quick picture. Here.
Give me a short balloon.
Five, 5080.
Abajo de pierna. Liz, look out, Liz. It's a cramp. Break it. Go ahead. Break the cramp. So, a lot of times these patients get cramps, and Elizabeth.
Especially after opening the CTO, PK, because you have more blood flow. anyway, so-
Yeah.
Yeah. It looks
Especially
like a
they're
cramp.
sitting on the laying flat on their back in one position is just a little.
So I want to check an ACT because of that common femoral. But honestly, in this case, I think we have to bite the bullet. One of the things that the FDA says is high restenosis, use a DCB. I think this one's going to be really high restenosis. Looking at it, the question is whether we should in this case or not. Because if you look at that common, give me an IVUS, guys. Let's do an IVUS.
PK, you think that area is a
thrombosis?
thrombotic, or?
I don't know. That's what I'm worried.
I think it's dissection. No, if you look at the previous IVUS also, I think the ostium was a dissection plane. I think that's all just multiple dissections.
All right.
I agree with you, but Vishal can remember last time, Vishal, when you came in to help me with the penumbra on the other side,
Yes.
that she thrombosed the.
Yeah. We're going back and forth between the profunda and the SFA.
Yeah,
so
we're having a mobile thrombus between the two. But I think it does look more like a dissection.
Let's take a look.
But with dissections, you can have an overlying thrombus as well.
Yes,
So it's just, it's very tricky to say one versus the other. There's always a component of the other one. So you can turn the chroma flow off.
All right. I'm just going to come from here. Turn. Okay. Good.
All the-
Dissection.
Yeah, there's dissection flap right there, but it's all on the side. And there,
Big time.
no, you have to there especially right there. That's your entry point.
Look at
Dissection.
that.
Look at
That's
that.
a huge dissection
Dissection
plane.
plane.
Look
Right
at
at the
that.
ostium.
Now there the chroma flow.
Right at the ostium. So I think here the question is, check an ACT, guys.
I mean, I don't think we have much of a choice here, PK. We have to stent it, right?
Yep, we'll stand it. So give us a 5.0 Supera distal, guys. What do you feel about that distal edge? Seen minus.
Yeah, can we see the picture?
The question is, PK, where are you going to extend your supera to, right?
That's my question. Look at your runoff.
Right.
Minus. 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 Now look at your Supera. Now where are you going to land your Supera?
In the adductor canal. There's
One-
one picture before.
One picture before
One more?
this.
Yeah, the 25 is shattered.
I would start my supera from 30 PK.
And just leave the rest, right?
Yeah.
Yeah, I think
I
so.
agree.
Yeah.
Give me a 5.0.
Just proximal to 30.
Yeah.
Give me a
Just
5.0.
29.
like at the before that.
5.0
after
long,
that.
150 is
Center-
fine.
Probably like between 30 and 31.
5.5.
I think if you go lower, you're
You're gonna-
a much smaller vessel.
I
You're
can
not.
give you a
Yeah.
5.0. I
That's the
prefer a 5.0.
problem.
Yeah.
It's
I
going to
think
elongate right at the distal end if you go more down
29 and a half.
because the vessel is not that
I don't know, Atul, because there's a dissection plane at 30.
big.
So
Right at 30.
So you have to go across that centimeter mark.
It's interesting that we crossed the.
PK, you want
well proximal.
PK, you have to balloon. You have to balloon a little bit again.
What do you want me to balloon?
You have to balloon at the
35.
centimeter mark, right? Because your stent has to start at the centimeter mark.
Or what?
Filter's still down.
Oh, filter's still down. Asma is reminding me the filter's down. We're going to capture the filter.
Yeah.
Yep.
So that was a 5-0 Dorado you used, correct?
Yeah.
Or a 6-0. So 5-0 Dorado just shattered the
I
whole
mean,
vessel.
you can still use the Supera with a filter, but
Yeah, we're going to do a filter picture as well.
yeah.
Mag up. Inject.
Problem is the vessel goes down all the way till the time it plumps up again at 5. So if you're
filter's
ideally
pretty full.
talking normal to normal, it's 5, but that's way down all the way into the pocket.
Yeah, I think you got to leave that. There's
Yeah,
nothing else you're going
I
to do.
agree with that. I agree with that.
But look at the plane like Karthik was talking about. Between 29 and 30, there's
Yeah,
real
we're going to have to
dissection.
come across it
Yeah.
and adjust. I mean, that's all we're going to have to do. There's nothing else we can do. Mag up on that
You're using a 5 or a 5.5 PK?
5-0 Chief. She's small.
Okay.
The vessel measured a 5. We ballooned with a 6.
Yes. Agree with
So-
that.
And we have a nice AV
What's
fistula
ACT,
somewhere
Lizzie?
right there.
All right, give me the Supera now. Yep, I'm just going to do it on the bare wire. I'm going to make sure I pull it out again, Karthik.
Now you have nobody to blame though.
I have a tool.
All right. Good luck, Atul. Keep holding.
It looks like the same brand.
No, it doesn't actually.
Okay.
No, it's just.
You're right, it does.
That's fine. We just
It
leave it
does
right
look
there.
like a same branch, no?
Just
PK?
leave it.
At least a branch of the.
No,
Yeah.
go- right.
I guess you can leave
You
it
leave
there.
it right
PK.
there. There.
I mean, bare wire is a stiffer wire, so you don't need that much support anyways.
I know, but I just figured that let me get it further down. It's going to move.
So this is a 5 or 150?
So 50, 150, 120.
120.
We didn't have a 150.
All right. We go all the way.
So remember, you want to wet the shaft of the Supera. Show me above, guys. And we're going to take it down to 30. Mag up now. So I think here, mag up really high. Little die here, please. So this is why we use the 7, so we can see where we're going to stent till. I think this is good, guys.
Yep.
You like
right
it?
there. That's
Right?
where. Yep.
So I'm just going to go forward a little bit here. Just try to get that Supera out. Okay, let me now get it pulled back to where I want it
Good,
to
good.
be.
That's good.
And then up against the wall.
Now here we have Sardar and Asma sing together for us.
Okay, cramp team. Cramp team.
Let me smell, Lord.
She has a cramp.
Let me smell. Okay.
Well,
Está muslo. Está
you're over
muslo
there, right?
solamente. Lo siento.
Mejorando. No más.
Vishal, would you have gone for a 5.5?
Well, I mean, I'm always a 5'5" preferred person, but
wanna come
especially
forward?
when we did Ivis here, and she's a small petite lady, a 5'0" I think would be ideal. 5'5" might elongate a little bit, because the vessel will recoil and come back, and then we have worse patency on a 5'5" rather than what we expect on a 5'0". So
Okay.
I think 5'0" is a good.
I think it measured a 5. We're
Yeah.
1-to-1.
We're 1-to-1.
my power.
We expanded with a bigger
Okay.
balloon. So
Just squeeze her calves here.
Ardi, what do you think? Would you have gone for a 5 or a 5.5?
I think a 5-0. You have to see her physique. She's very small. I looked at the other SFA as well.
Good.
The calf's fine. Perfectly
Okay.
fine.
Okay.
Perfect. So I think what we'll do is, obviously Alluvia would have been great here if we could, right?
Yes.
Yeah.
But,
Yes, agreed.
Unfortunately,
I think it's expanding really well.
Yeah.
Okay. And what are we giving her for sedation?
It looks beautiful.
and I think it's all just an example of vessel prep, A little bit of calcium there, a little forward pressure, but even there it's good.
Yeah, nice expansion. Very nice.
A little stacking there on purpose.
I think it's fine, PK. I think superior adjusts itself over time. After a month or so, I think everything, the whole stent adjusts itself. So
That's what they say, Karthik. I've never seen it adjust. I've asked my wife to adjust to me over time. It never has worked.
I mean, superiors are better than wives, so it's okay.
Better than husbands.
I'm just officially saying that should come out of the official record.
All right, walk
My
this
wife
out.
does watch the video,
All right,
so
yeah, I was going to say, you're in trouble now. All right, can I get another 550?
I guess I'm sleeping outside next 2 weeks.
You
So
think?
I think so, for sure.
If you're allowed to be in the house,
On the property.
on the property.
Somewhere in one of the corners of the property.
Asma's already texting her ham.
You're supposed to say superior is better than husbands.
50120. Is that a 55 or 50? 50. 50. I'm going to go with the 50 because it was a 50 all the way through.
And the ostial portion?
That's what we're going to talk about.
So you're taking a 5.5 now?
I'm going to take a 50 because it measured 50 all the way up. Right? He's saying 5.5. Give me a
5.5.
I
Yeah, I
would
would take
go
a
with
5.5.
Sandeep is giving me the signal from outside.
If Sandeep says 5.5, I would take 5.5.
150 if you have it.
Yeah, I think 5.5 is a good option.
So the question is, how do you deal with the ostium? Do you bite the bullet and put a Zilver PTX? Yep.
It's going to be a short bare metal anyway, so it's okay, I think. It's going to be probably end up being a 60 or a 40 bare metal. So I think it's okay.
Let's see. So again, I'm going to have Artie wipe down the shaft as he gives it to me.
So I think because if you put short, I mean superior, I think longer superiors are fine, I think. But I think if you put short BMSs, I think the patencies are going to be okay.
Yeah, let's see.
Yeah, I think if you say under 60 or under.
Yeah.
Yeah, but I think here the issue is, whether you think that the drug is going to be needed. Rail, please, for the ostium. But you're right.
I mean, it's more of a dissection.
It's a 3-vessel runoff.
Should be okay.
She has a great outflow.
So I think the question now becomes is, in this situation, how much do you overlap?
So two superiors PK, I would overlap pretty significantly, because as soon as you balloon, both those superiors will slide on each other. So
just 1 centimeter is maximum, which I overlap usually.
Yeah, that's pretty good, I think. You have to stack it there, because they really
Stretch out.
Yeah, stretch out a lot. They really elongate a lot. So you have to. That's nice.
Elongating a little bit.
Yeah, they always do, but you can stack it a lot.
One thing of interest is we already have Alluvia in her right leg. So the question is,
There's a good control.
Does that, or does that make us a little more inclined to say it's okay to use a drug-coated stent?
Oh, that's a good point, actually.
I don't know. Nobody knows the data on whether using X amount of centimeters versus not using an X, longer versus shorter drug.
So PK, just for the audience, and RDU and Vishal also, if you guys are using DES or DCBs, you guys are taking special consent forms?
I think that's the thought process. I haven't used one since the declaration.
Yeah, PK?
We haven't used one. Well, Sinai is working on its own consent form as we speak. So we will have a consent form very, very soon.
Okay.
And hopefully the meeting in June, I think FDA's meeting in June probably will give us an insight of what the future, the direction of this field will be. So we'll wait till it happens. So now the question is, eventually we've stented the whole segment, which I said we would.
What is that?
So we eventually ended up stenting the whole segment.
Yeah.
Yeah, here I'm having a lot of trouble.
So you want to lower down the mag and see where the ostium is, PK?
Yeah.
Yep.
Yeah,
Get the
because
mag a little lower.
it's elongating,
Getting.
you might come close to the ostium.
It's
So
definitely elongating.
yeah, you might come very close to the ostium, so you don't want to come across. See, so you are ending up right at that.
No,
That's
no,
it.
but it's going to come down now.
Yeah, it's going to come down,
show
but
me
you
above.
want see you are way up there.
Show me down.
PK, you want to really stack.
Yep.
Yeah.
You can pull back a little bit, not
No,
stack it
just
so
stack
much,
it.
but you want to pull back a little bit?
No, I'll stack it.
No, not necessary. It's going to come down. You
It's coming down.
already came down.
Yeah, they
PK.
came down.
You don't
Now
have to
I'm gonna
stack
pull.
so much, yeah.
Now you can. No, we're good.
It's really coming down a lot, so you don't have to stack so much.
Give me a little die. Yeah,
I think that's more than enough, yeah.
But you know what? It's better than putting it in the common femoral. You guys scared me for no reason. As
That's
always.
true. That's true. You know, that shows that we are not even immune, even if we are outside the room. So,
All right, now get me a short Zilver or a short BMS. What do we have?
Take a distracted
Absolute Pro then. 7.0.
What you can do is put a balloon in, inflate it, and pull back.
Let's take a look.
PK, you want to see the distal edge of the wire?
We're going to.
There's a lot of,
That's
yeah.
good.
Yeah. Okay, good.
I like it when it comes back like that,
Yeah.
especially in the supera. All right, guys, let's do a road map here. Ready? Inject. Okay, so we're gonna need probably a 60.
Yes.
Yeah, I think so. 60 is good enough.
Yeah.
I think 40 is good enough.
40 will reach right at the ostium.
I
where
would,
it's an
I
overlap.
would take a 60.
All right, give me a 7060.
A little bit more.
Yeah, you'll have some room to wiggle. So,
And give me a the question is, if the dissection is in the common femoral, would you or would you not do a DCB of the common femoral? I'm not going to because
I'm not going to do it.
I have good outflow, so I
I
don't
will
care.
do it.
You know, I think
I
it's a
don't-
non-flow limiting dissection of the.
yeah, I would.
You would?
No, I would leave it.
Yeah, we'll just leave it.
I would leave it.
You know, it's so funny, you know, in the coronaries, and we're all coronary interventionalists, and everybody in this room, we have so much data to guide everything that we do, you know? And here you're like, would you? Oh, I would leave it. No, I wouldn't leave it. You know, it's so embarrassing. Rail?
Well, I guess it's the vessel size and a different
But, you know, here I think you're right. I mean, I think it's going to be fine. We're not going to have to really worry about it. I'm gonna drop it right there, guys. What do you think?
Yeah, I think so.
Okay, ready?
You can even pull back a dot, PK.
I don't want to jail the profunda. This is pretty good.
I think the profunda is coming a little bit more higher than that.
Just a little bit extra overlap.
Yeah, I think that's good. That's good. Wherever you are, that's good. You might have to pull back a little bit, PK.
Just a touch back.
Just a touch back. You're missing the.
Beauty. Walk it out now. All right, give me a 6015 power, what is it called? A Viatrack. Yep, on
You're taking a
purpose.
60 PK, 6040.
6015. I'm just going to balloon that ostium.
Your wire is almost all the way back.
Yep, I see it. Artie likes to live dangerously.
On the edge.
The whole thing's stented.
And then we're going to get an IVUS finally. See, this is where you want to wonder whether you want IVUS, because, you know, it's like if it looks good, it looks good. You're done. I mean, if IVUS is not going to change your therapy, why bother, right? Don't you agree?
Agree.
Yeah,
True.
I agree. So no IVUS.
But at the same time, we already have an IVUS open, so why not have an extra pair of eyes?
Because then you're gonna be sitting around going, what should we? Yeah, chasing it.
I would not IVUS PK. It's a stent. You already stented it, so it doesn't matter.
Well, I don't think that's not. I'm talking about the common femoral here.
Yeah, I think
No, yeah,
I
common
don't think the
femoral, leave
dissection
it.
came into the common femoral, so I think you're okay.
This is obviously a renal balloon, 6015, and so what we're gonna do is we're gonna go down and just balloon the ostium here, and then balloon the.
We don't do renal stenting anymore, so PK thought probably will use up the balloons.
I just like the.
Inventory.
I just like the monorail version of this balloon. Go ahead, go up, guys. I like the fact that it's a monorail.
Nice.
10, 12, 14, 16, 18. Good. Okay, down. Very good. That opened
Want
up
to do the
nice.
overlap for the sphere?
Go up here. Go to 20. Okay, down. So I think it's important to get the overlap the way Dr. Kukar just mentioned. Go up here. I think Karthik and Vishal scared me from hitting the ostium. I would have nailed that ostium. Down. No comment. Go up here.
No, you would have actually. I think we did scare you actually.
No, I'm joking. Down. So the other thing you can do is try to align the struts by pulling back and forth on this balloon. If you elongate it, like so, for instance, like so.
Now you can push it.
Okay, or push one or the other. Down. And actually looks better. You see that? I think that's good. I don't think we need to do any more. Show me down.
The overlap of both the superas.
Right over here. Yep. Go up.
There.
One of them is definitely going to slip.
20. Down. Good. Okay. Let's take a picture. Low segment DSA. This is going to cramp. Okay, ready?
Oh, beautiful.
That outflow looks like poop.
I think it's okay, PK. I mean, it's disease vessel, so.
Yeah,
I
but
mean,
that's gonna maintain your superior, right? But this is the question: like, how much do you chase it? You know?
No, it looks
I
good.
think it's okay, PK. I think there might be some hibernating vessel there. It's a 3-vessel outflow. I think as long as the outflow is good. If it was 1-vessel runoff, I think it would have been a different situation. It's a 3-vessel runoff.
Yeah.
Uh,
I think it's okay.
Let's make sure that nothing happens.
With the
there.
rest pin and everything, is definitely going to improve for sure.
Inject. For what that was worth, it looks okay. I think what we'll do is we're going to put a catheter down and just puff out, just make sure we didn't perf offline. And then what we're going to do is we're going to look up. And I think this is part of the difficulties that we face, right, with deciding what to do with the outflow.
I think it's fine.
Inject. Thing looks okay. Give me some nitride, guys. I think we got to IVUS that ostium, boys.
Yes.
Give me an IVUS.
I don't know if it's a thrombus now. It looked the way it looks.
It's not. I bet you it's a dissection.
Okay.
Yeah, but let's do an IVUS first. Put me on regular. Liz, can you cramp patrol?
Like the
I think you
profunda.
can just balloon it also.
Yeah. Like a long, low pressure balloon inflation.
I'm just going to go into the stent and back. Okay, ready? Record. Stent looks really good. Now we're at the edge. Transition.
See, there's a flap.
It's
so
black with
No.
dissection.
That's with dissection.
Is that dissection?
Yeah, it looks
Yep.
like it's a dissection.
Now, see?
Yeah.
There's
I think we should do a short DCB, guys.
fine.
What do you think?
I agree.
Artul, are you comfortable with that?
I'm comfortable with
Yeah,
that.
I think
I
this
think we
is-
put a Louis in her other
Yeah.
leg.
Give me a 5-0 impact, please. 5020 impact. 5040 impact. I think we have to.
Do you want to take a little longer and coat the entire bare metal stent?
No, I think we'll be okay. Okay, actually Sandeep is suggesting Stelrex, but I think impact. I think our 5-year data with impact is so impressive in terms of patency that Stelrex doesn't compare.
But the Stellarex dosage is lesser than impact. And
Yeah,
I know it's a short segment you're going to say, so.
You know, but the problem with Philips, and as you know, our center was the National Center for Philips.
Yes.
You know, we still haven't published their 2-year data, their 3-year data. So, you know, we have the 2-year from UURCT, which was impressive, but impact is published 5 years now. So I think at this stage, we have to use the impact.
So you think it's just a dissection plane coming a little bit into the common
I
femoral?
definitely think it's a dissection plane.
Yeah.
Pull forward.
I have no idea who that is.
Do you want to mag up?
PK, the question here is if the dissection plane doesn't resolve, I mean,
Right,
it's
yeah.
not going to go away, of course.
Go.
But if it still looks the same, would you leave it?
No, I think it's, we know it's a dissection, and I'm not going to stent the common femoral at this stage. I think we're just going to leave it with a balloon, with a drug, and let the dissection heal.
Okay. Agreed. What would you do, Vishwan?
I don't know. I mean, from like how we know nowadays with common femoral stenting and the ease is becoming a little bit more easier in Zeller's data. If it doesn't really
Timer.
heal, then probably I would probably more be in favor of
Change out for
stenting
ultra
into
femoral
it
chief.
because
I-
if the inflow gets compromised, all the hard work is down the drain. So.
But I got to be honest with you. I mean, if it's non-flow limiting right now, and
Oh.
I think what we do is we'll take a look. If we need to put a short stent into the common femoral, we will.
Right, exactly. That's what I'm saying. We'll be.
Adi, what do you think?
So I think if we have a good result here, we leave it. I think if we see a clean cut dissection,
But more flow
That's-
limitation, though. I don't think we could go with it. There is going to be a dissection. We're not going to get
No,
rid of
but
the dissection.
I agree. I mean, it's just like you rightly said. It's the degree of dissection and how much it limits the flow.
Yeah.
I mean, it didn't look bad, but it looks horrible. I mean, if you really look at angiographically, it might not be flow limiting. So
But
I don't
it
know.
always looks bad. Dissections always look bad. You got the timer going? Yeah, we do.
I don't know. All right. So this is just like pretty much like a makeup.
Yep. I'm sorry. You want to go all the way? Yeah, right there is good.
All right. we will see.
All right, so I think we had a pretty good discussion on how we treat. We bit the bullet. We had to use a drug-coated balloon because we felt this was going to compromise the outflow for the stent, or the inflow for the stent. So all the work that we did, and I think we had a good discussion. I really don't think there is a definite therapy that we're all going to adopt now that drug-coated balloons may be off the market for the time being. So I think that it kind of takes us back to decision making on making sure that these patients, that we treat are being surveyed very, very closely, because I think the surveillance is going to make all the difference in capturing the restenosis early. I think that's the only option we have versus not treat them at all, which I don't think is a good option.
Agreed.
Awesome. I think it's going to bring up a lot of conversation in Link Mount Sinai, because obviously we're going to consent all the patients for drug-coated balloons prior to Link. So this is where we have all the options open. I think we're down, please. I think we're going to have a complete conversation, letting them know that, with the complexity of lesions that are being treated, especially live and Link, that I think that drug-coated balloons will definitely be the therapy of choice for us for these patients. Let's walk it out, please. So now we're going to walk this out.
All right. Everybody say cheese and we take a picture.
Okay.
I'm good with it.
I'm good with it too. The profunda is a little compromised.
Yes.
But I think the internal iliac is patent. Show me the iliac angio, guys. I don't know, man. It looks like shit. Looks like poop.
Yeah, I mean, I think RD, we are probably running into the same problem we ran last time on the SFA side, remember?
Yeah.
It looks the exact same thing.
PK, I think I'm okay with leaving it. If you take a more LAO shot, if you actually go more LAO.
Yeah, you might have to go a little bit more LAO to
I think there's a lot of overlap of the vessels there also. It's hard to say.
Yeah, but there's no flow limitation. I think, you know.
I'm totally fine with leaving
drug,
it,
I think it's gonna
especially
be okay.
if you
Mag
give
up, my dear.
DCB.
Can you mag up and go a little bit more LAO?
You want to take the wire out? And
Yeah,
see?
we can do that. I have no problem with that. I think it's just a dissection plane. That's all you saw it as a dissection plane before.
I'm agreeing with Vishal. I think it's a little thrombus.
Thrombus? Yeah.
Yeah, I think it's
All right, give me a penumbra, guys.
looks very similar to what she had last time, correct?
Give me a penumbra. Nothing wrong with that.
I mean, you're right. I mean, the dissection plane could give rise to a thrombus. It could be dissection plane, like you said. It's not that flow limiting, but I don't know. I mean, just.
I don't know if this is thrombus. I think this is a plane.
No, I'm sure. Like I said, it's a combination of.
We can
That's
send
my
the penumbra down on this and then take out the wire. Give me the penumbra.
PK,
So
I
we'll
think
put
it's
the
a plane
penumbra first and
extending
pull it out.
behind the stent.
Huh?
I think it's a plane extending behind the stent, just like we saw.
I think so too, but we'll take
Yeah.
a look.
I
I mean,
think
the only way you're going to make this look pretty is to stent it,
right,
and I think that's the whole idea, not to stent it.
right.
Right.
I think.
But I think it makes sense what Artie's saying. We run a penumbra. If it clears up, we look like geniuses.
I think RD. I think RD knows the patient pretty well, right?
Well,
RD?
she had a thrombus last time. Open it, please.
Okay.
Penumbra.
So I think just
Then we
close
just put the
follow up
catheter down,
after
we'll
2
take out
weeks
the
and
wire.
see. PK, is this a patient you would put the patient on Xarelto of 2.5?
So we
twice
so
a day?
I thought about putting her on Eliquis last time,
Cat 6?
and it turned out there was a problem with their pharmacy.
Not penumbra.
So it won't. They wouldn't. They
Well,
wouldn't
they
pay
open the
for it,
penumbra.
and she never.
I don't know.
ne-
What's this?
So
That's a
RD,
cat
I don't
three.
know. Eliquis is the is the approved drug. I think Xarelto 2.5 twice a day, which is a PAD drug. I think that's probably
Well, I would-
pretty good.
I was using more for the thrombus,
Thrombus.
not for the PAD.
No, I
portion
know,
of it.
I'm just saying, like, I think we don't have to be that strong on thrombotic areas. I think.
Well, so it's interesting. She didn't get the drug, regardless in the end, any NOAC, and you know I followed her every 2 weeks with duplex, and she, the thrombus is resolved.
You put her on Brilinta or?
Yeah.
Wait.
No,
wait,
Aspirin
but wait, were you guys able to suck anything out or
Yes.
no?
Yeah.
Yes.
Okay, rail, please, just rail. We got to change out the wires. So rail. So you were able to suck something
Yeah,
out?
so
Yes, yes.
we did demonstrate that there was a mobile plaque which just moved first from the profunda into the SFA, then common femoral. Eventually, we had to use a
Pull out the
multi-purpose
wire.
guide and suck it out to the penumbra. We were able to do that, but
Put the Spartaco down.
I think what
Pull it
triggered it, like you said rightly, was probably the dissection causing the
Pull it out.
triggering of the thrombotic phenomenon in this case. And
So RD, did you use a atherectomy device last time, or just
that's a good
No,
question.
just lithotripsy.
lithotripsy?
Yeah, he
okay.
did lithotripsy.
Lithotripsy balloon. Okay.
Yeah. No, I don't need one.
So is the penumbra set up?
Here.
There's two of you. You need to split up. One person do the penumbra. Wait, hold on, Artie.
I took it off to put the wire.
Yeah, but you have to put the wire in through here.
Is that a multi-purpose catheter? What
It's a
catheter?
penumbra catheter.
Oh, you have the cat.
The
3?
cat. Okay. Cat.
So we're going to just shove it into the stent. Good. Okay. Take out the wire introducer. Okay, whenever you're ready, you can turn it on.
Make sure you close the two in the co-pilot.
Coming? Okay, give me another wire here. Turn it off. Put an 035 wire down.
PK, would you have, and I'm just being probably not trying to complicate things, but would you have put a filter down if you're suspecting this, or no?
Nah.
Okay. No, like I said, it's
No,
just
for me, I don't believe it's a thrombus.
Okay.
I'm doing this for
us.
Placating me.
for you guys. No, truthfully, I just don't think it has the features of a thrombus. But who knows? We have IVUS that shows that it's a clear circumferential ostial dissection, which is probably extending into the common femoral.
That's exactly what I think.
But who knows, right? I may be wrong. I've been known to be wrong multiple times. Okay.
Oh, 3
Yeah, I'm just not gonna go too far in, too far out. On, please.
So Vishal and Karthik, are you guys using Angiomax exclusively for your peripherals?
Pretty much.
I don't. I think Vishal does, but depending on the case, if it's a CTO, I use an Angiomax.
Show me the.
Or if it's
show me
below
the
the
Yeah,
left
if
picture.
it's if I think that the case is going to take longer than half an hour, yes, I'll use an Angiomax. But if I think I can finish the case within half an hour period, I just use a heparin.
It's right at the ostium. So right at that below the 1 centimeter. I did it on purpose. So this is where like an angle penumbra might help, you know. Now let's go into the profunda now.
You use Angiomax on all your cases?
I use heparin
Okay.
exclusively. Although since that last thrombus, I've been debating whether I should be using more Angiomax.
No, I mean, it's just.
Yeah, as long as you're aware, I think it's okay. PK is just confirming that we stented the ostium.
I'm just trying to just suck everything out from
No, I'm
both
just saying
sides.
that's a good way to confirm that you have nailed the ostium. You want to puff a little bit and see?
I would test.
I think you're good. I think you've done it a few times.
All right, turn it off.
PK, my question is, does the penumbra suck in a mobile plaque or something like that, like a dissection plane?
Not as far as I know, Goosh.
Yeah.
I think that's all just plaque.
Yeah.
Okay.
We have TIMI3 flow.
Yeah, I think we're good.
I think you have plaque perfusion. The profunda looks good, right? Flow in the profunda looks good. The question is, do you want to balloon this one more time? I don't. Let's do
No.
an IVUS. Walk this out.
I would not balloon it. PK.
Yeah, I would not
just leave
balloon it more.
I think we leave him on Xarelto.
Yeah, we just DCB'd him. I think the DCB'd her. I think it's okay. I think
Let's do a quick IVUS and
Yeah.
see what this is.
RD's going to
She-
keep a
and she's
close
ve-
eye on it.
Well, she's very reliable, so
Yeah.
we'll send her for duplexes.
Yeah.
In
Just a
2 weeks.
duplex within 2 weeks.
2 weeks,
I
yeah.
think. Yeah.
Yeah, do quick IVUS.
And
Quick
then,
IVUS again,
then another
gentlemen.
duplex in within a month, and I think should be okay.
I think it makes sense to do that because we did it just to make sure. But I think you're going to see the same plaque that's sort of like a, how can you say, circumferential dissection right at that. You could stent into the common femoral short 20 stent and then see how it does. And since you've already drugged it, and that might not be a bad idea, but I don't think you need to.
RD,
Right.
I'm okay leaving it.
RD, if I were you, I would just send her to a place where the ultrasound is done, where you can see it.
See,
Yeah.
Yeah.
see that looks mobile now.
Yeah.
See
Yeah.
that?
That's I mean, my hunch is it's a thrombus, right?
Well, now I think it's a thrombus. Well, now I don't know. I think it's plaque.
I don't think it's a thrombus. I
see,
still
here,
think it's
here
the
may
plaque.
just be mobile. No, but I mean, it looks like it's
plaque.
behind. It's in the stent. See, now it's hyperlucent. See that?
See, the lucency of the vessel, and the lucency of that plaque is the same. So I'm assuming that's all a plaque protrusion. I think when you ballooned it, the dissection plane might have protruded it into the common femoral. I think that's my assumption because it's all the same.
Yeah. See that? It's plaque.
Yeah.
Now do you see?
I am very certain it's a
Yep,
plaque.
that's
but
plaque. I'm 100% certain. Let's go ahead and let's do something. Let's go ahead and put her on Xarelto, and then we'll follow her up.
So you want to do aspirin Plavix Xarelto 2.5, or just Plavix Xarelto?
No contrast, guys.
No, you can do aspirin, Plavix, Xarelto 2.5 twice a day.
So you wouldn't go with the full level of anticoagulation?
No, not necessary. I think just 2.5 twice a day Xarelto should take care of this.
Okay.
Yeah, you can see that plaque protrusion from behind that stent.
Well, I definitely think that it's going to help us to put her on anticoagulation regardless.
Yeah.
Lomé? I mean, you did everything you could.
I mean, the ballooning is just going to make it keep on getting it worse. So
I agree.
Yeah, ballooning is not going to help you. Either we just leave it, or if somebody is
stent.
aggressive enough, yeah. That's the only way to treat this as of now, with the degree of dissection and the plaque right there. Ballooning is not going to tack it up
there are
anymore.
only two things: either you balloon, either
You
you leave it or you
stent
stent it.
Yeah.
So
Right.
There's nothing in between.
I'm letting her move her leg a little bit.
So I'm good. We'll watch her very closely.
yeah, I think it's fine.
Look how small her vessels are. Really, really small, huh?
Nice.
Yeah, I think so. At this stage, we're going to stop. We're going to finish taking pictures.
I think.
And I think what we'll do is we'll go ahead and sign off here. But I think this is a very good demonstration of a CTO, a little bit of issues with the common femoral and how we dealt with it. And then I think, and now also some anticoagulation that we're going to deal with this lady. But you saw some of the complexities we face in the modern age of I would say the prehistoric age of non-DCB again, because now we're going backwards. But unfortunately, there is a important signal that we have to look at and take seriously. So in this patient, we did use a drug-coated balloon because we felt that common femoral inflow could have been a problem and might have closed off the entire SFA after all the hard work that we did. So at this stage, I think Dr. Kugrar eloquently said what he's planning on doing is, one, he's going to put her on Xarelto and on Plavix and aspirin for a month, and then continue her on Plavix and Xarelto probably, and then follow her closely in terms of what happens with this common femoral. The ideal thing that I would suggest all of you do is at this stage, before discharge, get a velocity at the level of the common femoral, proximal SFA. You know it's going to read 50 to 99%, but at least you know what that velocity is. And then you follow her symptomatically. You do one at 1 month, then you do one at 3 months, one at 6 months. And if it's stable after 6 months, likely you're not going to have any of the problems. If it does close, or if it does get worse, then the question has to come is, what are you going to do? I mean, would you go back in with an atherectomy device, try and cut it out, or would you go ahead and do a surgical resection? I think an atherectomy and cutting this out may not be a bad idea, but I think overall it's probably gonna stay open on its own. So I thank Dr. Kukar for such a great case, Dr. Farhan for presenting this case, and Asma obviously for all her help, and the two of you. We'll see all you guys next month before Link Mount Sinai.
I think great
So
job,
take
PK.
care again.
Great job, Artie.
Thank you.
Yeah.
Awesome.
I think we're done.
Thank you, PK. Thank you, Atul, and everybody in the team. Great case presentation. A great knowledgeable case to tell you what to do, and when to stop, and how to guide your decision making. So hopefully everybody in the audience learned something new today. Like I stated before at the start of the session, you can watch this case and any of our previous cases at ccclivecases.org. Please log in, send in our comments, concerns, or questions. We'll be more than happy to help. We'll join you next month, May 22nd at 8 o'clock Eastern Standard Time. Till then, me and Karthik, thank you very much and have a great day.
Thank you, guys.